Welcome, everybody. Come on in. Good morning. Letting everyone in, so give us a minute. Yes, great. Put in the chat who's here. I love seeing that. Jennifer, welcome. Connie, CCS is in the house. That's good. Who else is here? All right, San Francisco is well represented. Diane from FRCNCA. All right, Shasta, thanks for coming. All right. We got some folks from the rural counties up here. Okay, thank you. Annie, now it's going too fast for me. We're up to 68. Let's keep going. Butte County, wow. Hi, Children's Hospital Los Angeles is represented. All right, Carol and Patty, I see you. We really have great representation here all throughout the state. I love that there's so many of you joining us here today. We're up to 81. Let's go for 100. Good morning. Welcome everyone to the second day of our 20th Health Summit, 20th anniversary of our Health Summit. So before we begin, we will have Spanish interpretation available. So I'm going to invite the interpreter to give instructions verbally for anyone who needs them.
Thank you. Good morning. Buenos días a todos. Bienvenidos a la Cumbre de Salud. Si usted necesita interpretación en español, por favor, a través de su teléfono móvil, en el control de seminarios web, haga clic en los 3 puntos. Ahí va a poder escoger la sección de interpretación. Haga clic en el idioma que desea usted escuchar, en este caso sería en español, y quédese en el canal de español para recibir toda la interpretación. Gracias. Thank you.
Thank you, everyone. So please be patient with us as we try and get over any bumps we may have today. I am Dr. Yvette Baptiste. I'm the Executive Director at the Eastern Los Angeles Family Resource Center. I'm also a mother of 3 children that special healthcare and developmental needs. My youngest son used the ER quite a bit during his youth, so much so that men and women at our local fire department in Pasadena would give him a friendly shout out in the grocery store when they would see him. I've been an executive council member at Family Voices of California since the early 2000s. I'm very happy to support the work that Pip Marks and our team has led now for decades. at Support for Families. So Family Voices, just for a little overview for those of you who weren't here today, yesterday, Family Voices of California is a statewide collaborative of parent-run centers working to ensure quality health care for children and youth with special healthcare needs. Family Voices of California's priority is to improve health systems for children and youth with those needs and disabilities. Today, there will be a big focus on policy issues affecting our families. The overarching theme of our summits is to examine the challenges and the successes families have accessing care, treatment, and treatment. In other words, what is working and what is not working for families with disabilities and complex health needs. However, we would not be able to have this summit without some folks that I want to bring to your attention. First and foremost, our amazing and generous sponsors. So this is a shout out of gratitude to them all. You can see our sponsors on the Zoom platform, and I encourage you to check them out on the sponsor tab so that you can learn more about your organizations and the fine work they do for so many. I mean it. These are professionals and advocacy organizations that center youth and families in a big way in their work, and we're so very grateful for their support. An enormous thank you to our amazing speakers who are giving their time during the Health Summit to share their expertise and lived experience. Also thanks to our Summit Advisory Committee for guiding us on the planning of the summit. You guys work really hard and you start really early to help us to put this all together, and we appreciate your time and effort. Also, a big thanks to the folks behind the scenes helping with all the tech support. A special thanks to our wonderful event coordinator, Holly Wong, and her wonderful team. And of course, a big thank you to all of you attending today. Today, we will again be doing our door prize drawings to randomly select 4 attendees each day to receive $50. Yes, $50. That's an Amazon card. Okay, so the winners will be drawn during the closing of today. Keep an eye on the chat to see who wins. And I think they also announce it. And we will email the winners to coordinate. During our sessions today, you can interact in a few ways. You can use the chat feature to introduce yourself or interact with other attendees, and use the Q&A feature to submit questions for our speakers and panelists. At the end of the session's moderator will present questions as we have time. If you have any questions or issues, you can send a message to Holly or send a message in the chat that begins help requested. That's our SOS, okay? Help requested. And someone will come to your aid immediately. Today's session will be recorded and you'll be able to rewatch them later from the Family Voices California website. The Q&A will also remain on the recorded site, and you can share resources or comments there and in the chat. So please look out. Finally, let's make sure to look out for our event evaluation in your inbox after the summit concludes today. We really need you to take a couple minutes to do this. Your input is so important for us to find out what we've done really well and where we need to improve. And it helps shape our content and is just such a critical feedback for us. We really do pay attention to that. And I see that Senator Portantino is present and accounted for. So hello, Senator. I am going to do a brief introduction. We're so happy to have you here. It is my pleasure and honor to introduce you, State Senator Anthony Portantino. Senator Portantino represents California's 25th state Senate district. Prior to being a senator, and actually where we first met at my first summit was when you served as a state assembly member for District 44. And you probably, it was like 20 years ago, so you probably don't remember, but a group of us were in talking to one of your staff, and you came back from the floor and you came right in to say hello to us. I've been a big fan ever since. Senator Portantino has introduced several important bills and resolutions affirming the rights of LGBTQ+ people who have been victimized and brutalized, as well as legislation regarding care and access to medical and educational services for children and youth with disabilities. Welcome, Senator Portantino, and thank you so much for sharing your time with us for the next 20 minutes or so.
Thank you, Yvette, and thank you for inviting me and everyone for being here. You know, obviously, health in general, behavioral health, our children's health, you know, these are issues that we all care about deeply. And obviously, the pandemic has sort of raised the stakes. You know, everything we knew to be factual before the pandemic was, you know, hit home in overwhelming presence during and now after the pandemic. And, you know, I'm the father of a 21-year-old who lost her senior year in high school and then lost her freshman year of college because of the pandemic. And she was in that generation. And obviously, you know, little kids felt it as well as the teenagers. And so, you know, I saw with her how she coped and how her friends tried to cope and connect. And, you know, at one point I asked her about missing something and she said, "Dad, I've missed so much already. I'm over it." And, you know, it just was a sort of a tragic comment that she shared. So for me, you know, the lens that I've always tried to use as a legislator, as a dad, you know, what affects your kids affects my kids, what affects one child affects one family and, you know, the next family. And one of the things that I've sort of been encouraged by and excited by, I have two daughters a decade apart. So I have a 21 and a 31. And, you know, it's given me an opportunity. And obviously, you know, as a legislator, I speak to a lot of high school and college classes and I meet a lot of young people. It seems to me that this generation of young people is far more nurturing and caring about each other than past generations. They're really protective of one another. They look out for one another. And to me, it's very endearing and it's very hopeful. It's also indicative of that sort of, you know, intuitive way about them that they know they have challenges and they know that they have, you know, that the pressures are on them you know, far more significantly, I think, than past generations. And so I think it's encouraging, but it also sort of underscores the problem. And so for me, legislatively, that's where I've put a lot of my effort into education, into mental health. I tragically lost an older brother to suicide over a decade ago. Believe it or not, he texted me from the roof just before he jumped. He was literally standing on the roof when he was texting me. And, you know, obviously what it did to our family was horrendous and took a decade off my mom's life and just impacted us deeply as an entire family. And going through his mental health struggles, you know, his last year gave me another perspective. I was in and out of 3 different county hospitals with him during the time he was battling with depression, and it led to some legislative efforts to try to help that system as well. The other thing that it taught me is after his death was in the newspapers, you know, obviously I was an assembly member, and so somehow that became news. And so people who I never thought struggled with a behavioral health issue were coming up to me in droves. People I saw every week in the park on my walks when I would go to free concerts never brought up a behavioral health issue. But then once I joined the Survivors Club, once I was part of that, they all felt safe to share with me a story about their cousin, their aunt, their mother, their sister, their son, their daughter, you know, somebody who either had lost their battle to depression or was struggling with, you know, some form of behavioral health issue. And it really hit home just how prevalent and how pervasive the issue is. And so and how, you know, reticent and hesitant people are to talk about it. It wasn't until I was a safe person to share that they started to share. And so that's one of the reasons why I share my brother's stories, because I want people to know that, you know, it affects every family, including mine. And I want people to know that if we talk about it, we love each other, we share our stories, we care about each other, we bring it to the forefront, you know, we can get the care and sensitivity and the need to each other if we're more frank about it. I always make the joke that you go to a party and you'll talk about your cholesterol, your doctor's visit, your exercise routine. You'll talk about, you know, other health issues, but nobody ever says, you know, I'm feeling depressed today, or my son had a struggle today. You know, we'll talk about, you know, my son or daughter's sports injury, but we won't talk about a behavioral health. And so that's another thing that I try to encourage people to, you know, the more we share, the more we can care. And I think that's important. And so, you know, obviously legislatively, you know, I did the late start bill a few years ago to move high school start time back. And, you know, why did I do that? Because there was 35 years of research that said teenagers perform academically better and frankly think about suicide less if they get more sleep. And so, you know, here we are always struggling for ways to improve education. And we have a science-based, peer-reviewed research that says if you let your kids sleep in the morning, they're going to perform better and kill themselves less. I mean, imagine that based on science. I was amazed at how much opposition we got from folks who would get up and say, I don't dispute the science, but, and I would say, well, if you don't dispute the science, there is no but. You know, let's just do this. But it took 3 years. The whole world opposed it, mostly adults. It was adults who felt they were going to be inconvenienced by starting school later. And of course, there is no perfect school start time. No matter where you start, you convenient one family and inconvenience another. I mean, families have been adjusting to school start time, and there was no uniform start time around the state, you know, and so there's no perfect start time for everybody. The other interesting part of that dynamic is people would ask the right question. What's going to be the impact on working families? Perfect question to ask. And when I gave them the information, there were two camps. The information was that the child in the hardworking family, the child of the single parent, the child who is taking care of their younger siblings and has more challenges in their lives, that's the most sleep-deprived kid to start with. And guess who sees the biggest benefit from the late start? That kid. And so it's the right question to ask. The data says that kid sees the biggest benefit. And so some folks would say, oh my God, that was my biggest question, but now that I know the facts, sign me up. And others would say, well, that might be true, but I still care about that kid and I don't want to do it. And I would say, well, if you care about that kid, then you should want to do it because that kid will see the biggest benefit. And so, you know, some people ask the right question and then don't like the answer and then stick to their situation. But we got that signed into law. The other thing, when I found out that education code, there was a difference between behavioral health and physical health. So in education code, if you were home with a broken ankle or a cold, that was an approved absence. But if you were home with depression or anxiety, that was not considered an approved absence. So imagine being a 15-year-old wondering that if your teacher is going to accommodate you for being home because of anxiety, how much more anxiety that would have brought on to you. So we did a little bill that basically says behavioral health and physical health have to be treated the same when it comes to education code. And we think that little bill will make a difference. Going back to what I said in the beginning about, you know, teenagers being more nurturing about each other, we did a bill to mandate that behavioral health and mental health be taught as part of health class. You know, we know teenagers are opinionated when they don't have the facts. Can you imagine if we give them the facts, how much of a greater advocate they're going to be for each other? So we mandated that behavioral health be taught as part of health class. Now, there was a little wrinkle. The chair of the Assembly Health Committee made us amend the bill to only make it go to school districts that already teach health. And so that was about 65% of the school districts that teach health now have to teach mental health. Unfortunately, or my take is the districts that don't teach health are probably the ones that need it more than the districts that already teach health. So this year we have a bill to bring that back to make sure that the 35% of the school districts that don't teach health are going to be mandated to teach health. And so we're doing that. I also put the suicide hotline number on the back of your student's ID. So if you see the suicide hotline number on your student's ID and not the football schedule, it used to always be the football schedule when I was a kid. 99% of the kids aren't going to need that number, but if there's a kid out there who needs to call somebody, we want to make sure that that number is on their fingertips. The other thing is, parents, teachers, educators, most folks on a high school campus haven't been trained to see the warning signs of suicide. And we had a father who called in and told us about his 14-year-old daughter who turned in her English assignment, which was her journal, got an A on her assignment, and 2 weeks later killed herself. And he said, I'm not mad at the teacher for not seeing the warning signs of suicide in the assignment because the teacher wasn't trained on mental health first aid. But going forward, we should make sure that school personnel have been trained to know the warning signs of behavioral health challenges, not to be the healthcare professional, but just to try to help direct somebody to the help they need based on the warning signs that they've been trained to find out. And so, believe it or not, that bill's been a struggle to get through the system. I couldn't get a hearing on it. I got out of the Senate almost unanimously. I couldn't get a hearing on it last year in the Assembly. Now there's a new Assembly education chair this year, so I'm hoping we can get that heard. Same thing with dyslexia. There's a study out of Texas that has 50 to 70% of inmates in a particular prison are dyslexic. Think about that. You teach somebody to read, you give them a benefit for the rest of their life. If you don't understand their reading challenges, they're going to have lifelong struggles. I happen to be a dyslexic. I happen to actually have 3 learning disabilities. I drove my single mom crazy. When I was a kid, I got in a lot of trouble. And I like to say I was pre-Ritalin. So I didn't get the benefit of any medication. I just got into a lot of trouble. So I'm ADHD, imagine that. And I'm dyslexic. And then I have a third disability that most people have never heard of. I'm cross-dominant, which means I'm right-armed, right leg, but left-eyed. So my left eye is my dominant eye. Most people have a dominant side. I have a cross-dominant situation. And so here I am, 62 years old, and the most stressful thing in my life, I could speak in front of 1,000 people and not even think about it. But if I go to a retreat and they hand me a pen and they say, here, be the scribe, that's a stressful situation because I don't want people to see how poor of a speller I am and how poor my penmanship is. And I don't want to go and write on the big board. So that today, of all the things in my life, that's the only thing that causes me tension. And so again, I understand how it is when kids face these challenges. We have a bill this year for special needs students to have part of their IEP, to have evacuation plans, to have, let the schools know how, if there's a disaster or God forbid, a shooter or somebody on a campus, do the special needs kids have a plan? Do the school district have a plan to deal with them? And so we want to put that in their IEPs. Last year, the fetal alcohol syndrome moms came to me and said, we don't have our own IEP category. We get misclassified. We get put into other categories. You only get an IEP if you fall into something else. And so there's, again, so many misdiagnosed children with fetal alcohol syndrome disorder that end up in the criminal justice system because they didn't get the care and the love that they needed because they weren't properly identified and properly treated. And so we did a bill last year to make sure that fetal alcohol syndrome gets its own IEP, and the governor signed it. So I was very, very happy about that. We're coming back this year with the dyslexia bill because, again, if you're a suburban parent and you're in tune with your kids, reading in the first grade, at 15 minutes into the first grade, whether your kid has a challenge, and that kid's in a pediatrician's office by Friday. But there's a lot of hardworking parents that don't have that pediatrician on speed dial, and there's a huge social justice component. My mom didn't find out until I was in the 8th grade that I had a learning disability. By then, I became a listener, not a reader. And I would, it's cheaper to intervene in the first grade, and it's easier to intervene in the first grade than it is in the 8th grade. And so those are some of the things that I'm very, very passionate about. Obviously, we got to talk about these issues. We got to bring it to the forefront. I've been trying to put a bill forward on autism to create more treatment opportunities for autistic children, make sure that the parents don't have to go out of pocket to pay for different evidence-based treatments. That's been a struggle. We've seen some opposition to that, you know, again, on cost. But again, what's the cost of a 7-year-old's, you know, life and future? You know, we help a first grader. If we don't, you never get the first grade back. And so, you know, that's why I'm doing so much on the early intervention and the early issues, because we got to, you know, I always make a joke, there's only 120 legislators. So that's not the biggest job market for kids with learning disabilities. So we got to make sure that we help them along the journey. Yvette, I don't know if you want me to take any questions, or if you want me to keep talking about different legislative proposals. I'm happy to take a question or two, or I'm happy to keep going. I, you know, want to be respectful of everybody's time.
Yes, I you know, you're getting a lot of love in the chat, and you know, I don't know if you can see reactions. This is a group that this is your people, Senator. We just a lot of the educational and even some of the health related legislation which you've put forward are so important to our families. Let's see if there are any questions in the chat.
Just to tell everybody, I mean, you know, obviously no parent is a better advocate for their kid than that parent. Nobody, you know, it really is, you know, we all have to work together, and, you know, being on a school board is a very difficult job. You know, before the pandemic today, and, you know, parents, you know, should be involved, and, you know, we need those dialogues and conversations, you know, help us all. And so I just want to say thank you to all the activists and parents and people who are involved in the process. You know, obviously we want a respectful discourse. We want it to be productive. It shouldn't be, none of this stuff should be angry. It should all be positive moving forward. And I think out of the conversation, you know, we get better decisions, and we, you know, we do things together. And then I always come back to something Mother Teresa said. I didn't know her. She was a little older than me. But Mother Teresa said, when they tell me my efforts are but a drop in the ocean, I say, isn't the ocean better off for that drop? And so we all put a little drop of positive love in the ocean. It just becomes a tidal wave.
Yeah, it's like the starfish example, right?
Yeah.
You can save one today. That's the first grader example. I think I'm gonna go with that one. That was good. They're only in first grade once, and, you know, if you can help them in that moment, you know, that's important. They are the group here is letting you know that they are here if you need family stories, particularly around dyslexia and the disaster plan in the IEP. Those are very significant issues. Also, I didn't know that you had done the bill related to the bill. I think it was the one that was related to the later start time for high schoolers. That was really important. And then we have some folks from mental health here who have been doing the first aid courses, kind of training people around that for mental health. So, you know, we have a list. If you need us, we can call on a lot of families.
That would be great. I see in the chat some folks wanted a little bit more on autism. So when Darrell Steinberg wrote the original insurance coverage bill, they named only one particular treatment is covered by insurance. And so what we have is a bill that basically says, if it's an evidence-based doctor prescribed treatment, that should be covered. It shouldn't be defined as just one particular autism treatment. It has to be evidence-based, doctor prescribed, medically necessary. And it should, so obviously we get some opposition because that means that there are other treatments that would be covered by insurance. And so the treatment that is the only one covered, they're not happy about sharing the space. And then obviously the insurance companies aren't happy about having to pay for additional coverage. But why should a parent who sees benefit from another evidence-based treatment have to pay out of pocket?
Right.
When, again, and it's evidence-based, doctor prescribed, medically necessary.
Has that bill been introduced yet? Does it have
It's been vetoed 3 times.
Oh,
We're working on it. We're working on a 4th time.
all right, let us know. Do you know, does it have a bill number or are you?
Not yet.
You're
We
gonna
have a
introduce
spot
it
bill,
again?
so we're trying to negotiate, since it's been vetoed 3 times. We're trying to negotiate a solution this year. So that's my hope.
We had a really good comment in the chat about the term of the use autistic, that maybe that we might need a broader definition in that law.
Yeah, I see that. Yeah.
Neurodiversity versus, because there's some conditions that are similar in the need for that treatment.
That's what happens when you have a filmmaker being a policymaker. I'm just a dad. I'm not. So I sometimes don't use the right nomenclature.
Oh, that's okay. This is, we're in this together. So
Yeah.
There was also something about epilepsy. Did you have a bill related to epilepsy?
We have a bill this year that the Epilepsy Foundation came to us to give more flexibility to doctors in the communication with the Department of Motor Vehicles, and it's to create more discretion. And so it came to us from the foundation, and so we're working with them on that.
All right, Senator, is there anything, last things you'd like to share? I really have enjoyed having you and being able to talk to you. And we can tell from all the love that you're getting in the chat and the reactions that this group is really, you've really connected with this group, and we're here to help.
Well, thank you everybody for spending your morning with me. And what affects one of us affects all of us, and just we'll just keep working. I always say you got to believe tomorrow is going to be better than today, or you don't get out of bed. All right, take care.
And it's always good to get out of bed. That first step.
Yeah.
It hits the floor.
Yeah. Be well. Take care, everybody.
Thank you, Senator.
Bye-bye.
All right. He was great, wasn't he? Yeah, I see a lot of love coming in here. And Pip, it might be great to kind of save that chat, go through that chat and send those comments to him. I think that would really help him in kind of knowing how much support he has, at least from us and in the community, for his work. So Alex is queued up here. I just want to announce that the next plenary session is about to begin, and that's behavioral health and children and youth with special health care needs and disabilities, the challenges and opportunities families are facing today. So I'd love to introduce Alex Briscoe. Alex is the principal of the California Children's Trust. Welcome, Alex, and all the speakers for this plenary session on behavioral health.
Thank you, Yvette. Yeah, what a nice way to be inspired by an elected official. Sorry, what a great way to be inspired by an elected official. That was delightful. Yeah, there's such a fierce practicality into the things that Senator Portantino is working on. It's so hopeful. Thank you. So I had a mentor who once said to me that we're all better when we act on the exhale. So I want to invite all of us to do that, because we're going to take on a bear of a topic here, and one that I know is super important and pressing to the children and families who we all work on behalf of, particularly those with special healthcare needs. And we have an amazing panel of state leaders, and you're going to hear lots of stuff that that people are up to. But I also want to begin with some clear-eyed kind of understanding and about where we're at, because we're not starting from a good place. And I say that both in terms of what's going on with young people, but also our unfortunate efforts to date to address these challenges. So I'm going to do a little bit of framing. For those of you who don't know me, everything I'm about to talk to, I have lived. I think I've billed just about every version of Medicaid, Medi-Cal that there is in California. I worked in the Oakland Public Schools and at the emergency department at Children's Oakland and in foster care and juvenile justice, and eventually administered a county system with a CCS program. And anyway, I kind of feel like I've been living in these waters, and we're now about to do a bunch of stuff. And I'm hoping it's going to make a big difference. So we want to begin by framing that for you. And then I'm going to pass you off to some of the leaders in the field, including folks from DHCS and the health and hospital systems and advocates who are going to give you some more detail. But just to begin, I'm going to do a little bit of stuff here. And I'm going to ask you to suspend disbelief, which is a term from literature, and go with me, because so many of the changes we're talking about right now tie back to Medicaid. And it's hard sometimes, I think, for us to give the grace and generosity of spirit to California's Medicaid program. It's the largest in the nation, and by any standard measure, we've really struggled with kids. But there's some extraordinary leadership at the state and local level that is trying to reimagine our program. And I'm going to focus a little bit on what's going on and the context for it, and hopefully give everybody who's listening some tools to make sense of an unprecedented reform landscape. If you ever were a kid, or you know a kid, or you have a kid, you are probably worried about their social and emotional welfare, whether they have special healthcare needs or not. And I think, as I'll show you in a second, there's good reason for that worry, but there's also good reason for hope. And I'll just begin with, when I'm often asked sort of what makes me hopeful about youth and young adults in California today, one of the first places I go to is the courage of young people to question some of the fundamental building blocks of our culture, particularly gender, sexuality, and identity. Like, if young people are willing to question those things, then I think there's great hope for young people to learn how to navigate this toxic culture. It is, I can tell you, in my career, we've never had as much focus on this topic. Like, I'm not making it up. I think you probably know that what I'm saying is true here. This is a once in a generation opportunity to impact the social and emotional health of children. Like, it hasn't come before. I doubt it will come again. A confluence of factors came together to make it possible. It begins with leadership. State and federal administrators have established a focus on children's well-being. I'm actually in DC right now, and I can tell you it's not this way in every state. I couldn't be more grateful for the leadership of HHS, DHCS, and the governor's office. But Californians have been demanding this change. Repeatedly, Californians say this is really important. And Dr. Harris and many other people have established for us an extraordinary research base, which is inviting us to think differently about mental health. And if I spontaneously combust and you take nothing else from what I'm about to say, I hope you will join us all in reimagining mental health as a support for healthy development, not as a response to pathology. As I'll show you in a second, it's not young people, it's us. We have built a culture that young people need new tools to survive. And that's not because of them, it's not individual pathology. It's because of a context we've created. And I can say, as someone who's probably billed $100 million to adjustment to disorder not otherwise specified, that a very small percentage of the families that I have served were actually mentally ill. The vast majority were dealing with really, really bad stuff in their lives, like being really sick or sleeping in a car or being told they weren't worth nothing. And we're about to spend a bunch of money. One of the confluence of events was a $100 billion surplus. So there's actually $10 billion coming into the system, and it's up to us to make sure it gets spent in different ways. And to take advantage of that moment, we have to reform. We simply must reform how we pay and do, how we finance and deliver. Everybody sees problems in the context of their solution. And an invitation I must offer to all of us is, more of us isn't always what's required. We need to think differently about who does the work and who gets paid to do it. And that ties back to this idea that what's going on with young people isn't necessarily individual pathology, though there is mental illness, please. I'm not trying to say there isn't. It's just a very small percentage of what actually has to happen to reform our children's mental health system. Just to give you a couple numbers, and the reason I show these numbers is to make sure none of us falls into the trap of talking about this like a pandemic related thing. Everything I'm about to show you comes from before the pandemic. In the decade before the pandemic, we saw a 104% increase in admissions for self-injury. We saw a 50% increase on pediatric bed days. Kids were telling us we weren't listening. Kids were telling us and we were not listening. This is from the California Healthy Kids Survey. Young people were self-reporting a dramatically increased need for social and emotional support. And this is not any shade or attack on any individual person. That number, that 44th number, that's me. That's all of us who've been working in the system. What we've done has not been sufficient. We rank 44th in the nation in access to care. We must translate our good intentions to practice far more effectively in this state if we're ever going to do right by kids. Why is Medi-Cal so important? It covers 6 out of 10 kids. Like, it's already the dominant payer. Like, we can't fix this problem if you don't fix the dominant reimbursement methodology. And for those of you who are policy advocates and how did we get here? Well, in 2015, we did 2 really big things. We rolled in our SCHIP program, Healthy Families One Away, and we added undocumented kids. So now all children 0 to 266 of FPL, that's actually wrong in the slide, it should say 266, are now covered by Medicaid, which is a unique federal entitlement. But unfortunately, less than 6% are getting access to anything at all. Less than 3% are in ongoing care as measured by 5 or more visits a year. We have a lot of work to do. As I mentioned, almost 60% of all California kids are in Medicaid, and primarily they're served by these 2 delivery systems, the managed care system and the mental health plan system, counties and managed care plans. And, you know, again, as an advocate now, I can say this, and if you look out and see the forest through the trees, more and more and more work is being done through the plans. And the mental health plans, the county systems, are being more narrowly focused on system-involved kids and higher acuity kids. So if you're looking for new stuff, meaning what more are we going to do? So much of that is coming through the managed care plans. And I know that can be, you know, we can debate up and down, left and right, whether, you know, that's good or bad, but it's the reality of the state's proposals under CalAIM. Understanding how to better leverage support through your managed care plan is a super important issue for us all to tackle. So I'm going to teach you Medi-Cal in 2 slides or less. It's actually really simple on the surface, right? Every Medicaid expenditure has 2 parts. It has a federal share and a non-federal share. We have fancy names for those, right? We call the non-federal share a certified public expenditure, but all that means is it's a public dollar that's not already being used to match a federal dollar. And we call that federal dollar federal financial participation. So basically, think of Medicaid like a pot of gold sitting in DC. You put up $1, you get $1. So let's track how that federal dollar shows up in the lives of children and families. And this is the architecture of our failure. That's what I'm about to explain to you. Well, we know that the big 3 are managed care plans, county mental health departments, and school districts, whether it's through the IDEA, whether it's through county mental health plans, or whether it's through the non-specialty mental health system that's growing and growing and growing. These are the big 3 of Medi-Cal, but there's more, right? There's also community health centers, public health departments, public hospitals, and the regional center, which is itself a 1915I and 1915H waiver program, meaning it's a Medicaid program. So those of us who've worked in these bubbles know that you spend a lot of time pointing your finger at the other one, saying, no, it's you take it, you do it, it's your problem. And what is coming in CalAIM is an effort to set up the managed care plans as the healer of this fragmented safety net. All kinds of problems with this. You know, we're seeing some kind of mixed outcomes with how CCS is working in the whole child model plan. So please, we have to be open-eyed and, you know, clear-eyed as we do this work. But if you want to know why it's so hard to navigate the system, it's because we've architected it this way. So just to leave you with some hopefulness, if you ask me what is the most like active reform setting, like where is new stuff happening in the most, I could tell you that literally there are 1,000 new programs in schools. Like, I think it's probably fair to say that 30 to 40% of them aren't so great, or they're just learning, or they are whatever you call something that gets starts up. But one of the problems that we have with this vision of managed care plans doing more for kids is that managed care plans don't do so good by kids. They're 42% of enrollees and only 14% of expenditures. So we have to manage how young people show up in the lives and experience of managed care professionals, because kids have historically not costed enough to drive and UR and investment strategies and plans. But the healthcare system needs schools. If we're going to do mental health right, and particularly for the children who are at the heart of the crisis, those 8 to 18, we simply must do it in schools. There's no other place. That age has the lowest rate of primary care utilization. They go to the doctor the least. So part of what's happening with Youth Behavioral Health Initiative and some of the work that DHCS is leading is we are in the process of legitimating schools as essential actors in a reformed network of care for kids. Schools aren't just a handout to plans. It's really important that schools and all of us help support the evolution of schools as essential network actors, just as important as hospitals and ambulances and doctors' offices. And the finances align. Actually, one of the great hopes is that we can do more through schools. So there's all sorts of opportunities there that I won't go into today, but we should talk about more. But schools, like, think about schools as a new and emerging place for kids to get support. We're also recognizing that behavioral health delivery must change, meaning that we don't give everybody a CAT scan. Why do we give every kid a 50-minute session? And one of the things we're looking at is how to build a more culturally congruent workforce that doesn't focus on traditional psychotherapy as its primary modality of service delivery. And specifically, we have created 4 new provider classes just in the last 2 years: doulas, community health outreach workers, and actually not called behavioral health coaches now, we're calling wellness coaches in schools. These 4 new provider classes represent an opportunity to bring somewhere between 5,000 and 10,000 California residents with relevant lived experience into our workforce at a family sustaining wage. That last part is really important. Nudge, nudge, again, to Senator Portantino's really important point about that we need to do this with love in our heart. Everybody is doing the best they can, but some of the rates that are emerging for these positions are too low. The doulas are coming out around $1,100 a session. That's a good number. The CHWs at $28 a 30-minute session are too low. We really have to make sure that when we bring marginalized communities into the workforce and we center and honor the lived experience, that we pay a living wage. It simply will not work if we don't. Some of the considerations for how to do this can get a little complex. They're listed here on the right-hand side of the screen. What do people do? How do we credential them? How do they sign up to get paid, paneled? Who pays? Which bubble? And what are the rates? So there's a lot of this negotiation going on, but I think this is one of the great hopes of the reform landscape is schools, new provider types, and changing the criteria for entry. So for a lot of us who've been working on this topic, we've been looking for ways to help kind of the field understand why it's so important not to pathologize the Medicaid population. Remember, 81% of kids on Medicaid are kids of color. Almost 80% of the master's level clinicians are white. And acknowledging that we're all doing the best we can, it is simply not right that we pathologize low-income children of color for the paycheck of a largely white professional class. And one important way we can reframe mental health service delivery is by removing diagnosis as a prerequisite for care. As I mentioned, 10 to 15% of all the kids I've served over many years were actually mentally ill. The vast majority were dealing with tough stuff. We, for the first time, and we're actually leading the nation in this space, are reforming the criteria for entry. In specifically, the new family therapy benefit is the first Medicaid benefit in the history of our nation that qualifies poor people for access to care based on an experience of discrimination, based on housing instability, based on food insecurity, or the 8 other adverse childhood experiences. It's a groundbreaking benefit paid through by the managed care plans that is, for the first time, I think will help honor what people are actually going through and what's driving the social and emotional challenges that young people are experiencing. We're also, about just January 1st, we did a really big thing, which is we adopted a brand new benefit called the dyadic benefit, which is a way for caregivers and children to get mental health support during the well-child visit. Low-income communities go to the doctor the most frequently in the first 3 years of their child's life, between 10 and 15 times. And if you've ever been to a well-child visit day, you know it's a unique experience. It's like a party. People are hugging, there's balloons and flowers in the waiting room. It's usually the clinician telling the mama or caregiver that they're doing great and that their baby's awesome. It's a great time to do social and emotional support. And for the first time, and again, leading the nation, we just rolled this benefit out January 1st. It's going like crazy. It's going to be an amazing thing. So let me end with 2 slides. First, trying to track all that's happening is really hard. And I would suggest, I won't go through the details here, that you look at it in 3 different buckets. The first is understanding the Youth Behavioral Health Initiative. It's a big thing. It's $4.7 billion. A lot of it's one-time money. There's all kinds of issues. We can't solve all the problems at once, but understanding the Youth Behavioral Health Initiative is a good place to start. Understanding CalAIM and the redrawn map of Medicaid, particularly in the mental health space between the managed care plans and the counties, is really important. So understanding what new benefits are coming in community supports, enhanced care management, and sort of the CalAIM bucket is another important thread to track. And then finally, a number of things have happened directly through the budget, particularly for schools, community schools partnership, expanded learning opportunity, but also mindfulness programs and others. So I think these are 3 ways to try to divvy up the reform landscape and hold all the investment that's coming. So let me conclude with kind of a lead into our amazing panel. Our call to action at the Trust, but this is stuff that we've worked on with everybody here. So there's nothing that's gonna, there's no ownership at all. This is stuff that I think the field generally accepts we need to do. We need to reform the definition of medical necessity. That has been accomplished in the 1915B waiver, where all system-involved kids are now automatically eligible, and you're also eligible for if you've experienced trauma. And it's also been done through the non-specialty system managed care plans through the family therapy benefit and the dyadic benefit. Clearly, the future of children's mental health is going to be written in pediatric primary care in schools. We have to expand who does the work and who gets paid to do it, shifting agency and power. And we must develop mutual aid, cascading mentorship, and social model programs, meaning people, when they are brought together and share their experience of suffering, magic happens. Like, I can't help but reflect on what my mother did when she got ovarian cancer. She joined a Facebook group and spent every night talking about which hospital had free parking, which chemo was best, what worked for her diet. Marginalized communities have incredible wisdom and intelligence, and linking people together to help them support each other is incredibly important to the future of social and emotional welfare. And finally, technology really does matter. I did something with the Melinda Gates and the Mackenzie Scotts of the world, and I learned at this thing that over 400 million children are currently spending 4 to 6 hours a day in digitally enhanced environments. And we can debate up and down, left and right, whether that's a good thing or a bad thing, and who knows where you are on that, but we have to go where kids are, meaning simply scheduling appointments and having kids going to 50-minute sessions in office parks is not the answer to the future of mental health. Building trust, building alignment, and going where young people are at are essential to the future of children's mental health, and that means creatively leveraging technology. I'm going to pause and introduce the first speaker from our panel, so I'll stop share. Thank you for listening, everybody. It's a pleasure to share this work with you and everyone on this panel. It's a pleasure for me to introduce a colleague of mine first. Thank you, everybody in the chat, so sweet. I'm going to introduce Nancy Netherland. Nancy Netherland is the director of Kids and Caregivers, and she is also the director of parent engagement for the California Children's Trust. Nancy, take it away.
Thank you so much. I'm going to ask for my slides to be put up. And while that happens, I am a mom, and I actually, before I was a mom, I was a MFT, and I worked in healthcare for the homeless, and I worked in schools. And more recently, I'm a mom who's also an activist. I want to say before I present this that everything I share is approved by my daughters. And I usually have my daughters with me. Sarah, who I'm going to talk about today, is really having a difficult time being in public of any kind. So she has asked me to speak for her. I think deeply of what our opening plenary speakers spoke about yesterday from Little Lobbyists, the importance of having our children share spaces with us. And my kids do. We've spoken in front of the NIH and the White House and Congress. But right now, Sarah is struggling with selective mutism and some sensory processing disorders. So I'm here speaking for both of us. I'm going to ask for the next slide. Thank you so much. So my daughter, Sarah, is 16. And before I go into this slide, I was talking to my sister, and she's also does a lot of policy work. And I said, I'm doing this presentation and I feel like I am such a downer because it's been really hard around behavioral health to get care. And, how do I deal with that? Because I work with all these amazing advocates, and I've seen brilliance coming out of our legislature. I've seen incredible work coming out of the department. I'm so inspired by the people I work work with, with the Medi-Cal Children's Health Advisory Panel and these CalAIM work groups. And I don't want to rain on the parade. And she was like, don't you wish you could just blow glitter and fairy dust on the system and just make it work? And so that's what this slide has, is some glitter and fairy dust to say that I share these experiences with an awareness of how hard everyone is working and how much we have pending, but also the reality of how hard it is right now. So Sarah is a former foster youth. I met her at 3 months old, and it was like instant love affair. She was diagnosed with hepatitis C and, hadn't had prenatal care, and her mama had had a super rough time of it, you all. And it was really an opportunity to let Sarah have a child. She had a lot of medical stuff. So my husband and I adopted her or fostered her. And she needed clinical trials and a bunch of stuff. So going into that, I was aware, because I'd worked in healthcare settings as an MFT, that, people, and especially kids with chronic illnesses, have some different behavioral health risk factors. And so I wanted to really be proactive in getting her care. Now, along the way, we lost her father. He is a Black man, had a really hard time getting behavioral health care and actually accessing the system of care, and really struggled. So we lost him. She had liver disease. And so I was like, I'm going to get behavioral health care. And I have to tell you, it did not go well. We have the best pediatricians on the entire planet. And I have all kinds of privilege based on my professional background, my skin color, being able to speak English. We could not get care because, you know what? It was not covered. So when we lost my husband, we began accessing Medi-Cal through the Adoption Assistance Program for children with special health needs. And I was really shocked. That's part of how I ended up founding Kids and Caregivers. That's a whole nother story. But anyway, let me go back to Sarah. So Sarah, over the years, has had hepatitis C and was up for a liver transplant. We got in a clinical trial that was great. After that, she ended up breaking her bones and lost the ability to do sports, which had really been her go-to resiliency opportunity. And then her sister got very, very ill with multiple illnesses, including an incurable rare disease that has her in the hospital quite frequently, and her health declines regularly. Sarah also started having what was assumed to be oppositional defiance disorder. And luckily, I was like, hey, I think she might have learning disabilities or sensory processing issues. And I say lucky because Dr. Calhoun had done some really great research, as other researchers have, on the disproportionate numbers of Black and Brown children diagnosed with ODD instead of different types of behavioral health and learning disabilities. Sarah has sensory processing disorders and recently has been diagnosed with selective mutism. She has a lot of trauma also. So that's a background. So I want to tell you where we are now. So Sarah identifies as African American, genderqueer, gay, and a lover of dogs, natures, and graphic novels. The system identifies her as a medically complex former foster youth who's biracial with multiple behavioral health diagnoses and an elevated ACEs score, who's insured by Medicaid. She's pending diagnosis for some neurodivergencies. Right now, she's got a bunch of learning diagnoses, disabilities diagnosed, depression, anxiety, ADHD, sensory processing non-specified, and she also lives with a rare neurological pain syndrome. So this is Sarah's behavioral health resource map. So there are a lot of points of entry for care if you look at it, right? There's primary care, potentially with a CAP consult. There's school. School's been a really great resource for her. There's school counseling. There's special ed. There's ERMS, educational related mental health services, medical specialty psychiatry, county specialty mental health programs. Sorry, fighting a cold. First, foster care urgent response services, neurodevelopmental pediatricians, excuse me, and community-based services. So what I'd like to do is go to the next slide and tell you, so this is what it could be and what's happened. So over this is just kind of our last 9 months. Over the last 9 months, despite being a kid with a 1915B specialty mental health eligibility and an elevated ACEs score with presumptive eligibility, we've hit a lot of roadblocks. Primary care has had staffing shortages. I'm sorry, you guys. The schools really come through for us, though it didn't. We actually originally litigated for about 5 years, and then we've now gotten the services that we needed. Psychiatry through medical specialties had payer problems, waiting lists, and staffing shortages. County mental health has had payer problems and staffing shortages. And I don't need to go through this. There's kind of a theme in trying to access care around shortages, waiting lists, and payer problems. I will say that Sarah had a remarkable, and some of you may know her, she does a great video series for UCSF, Monifa Willis, amazing psychiatric nurse practitioner, woman of color. It was a total, like for my daughter to see representation of a Black woman providing specialized mental health care, it was amazing. Unfortunately, there was a glitch with her referral and it got closed and she wasn't able to get in and again to see her because there were no new referrals being accepted. And I mean, I cried when that happened. I pushed, I fought, and I cried because it was such a big deal for my young person, my daughter, to see someone who mattered and was so relevant and also such a skilled provider. So the specialty mental health services, Sarah's had mild to moderate, but in waiting for her, we basically had to wait till she had a diagnosis. And it's kind of a slippery slope. Once you get a diagnosis, it's much harder to treat. So she's now needed specialty mental health services. It's been really difficult. It's a fragmented, under-resourced system of care. And we've had a really hard time getting services. I'm going to ask that we go to the next slide. So, you know, for those of you who don't know, there are kind of two sides to healthcare, especially when your young person needs specialty mental health care. The system divides the mind and the body, right? It's just interesting to think about the fact that we really have the same young person, but we've got two separate systems of care. So I think of this a lot of times with the divide, because even if her pediatrician or her neurologist wanted her to get care over on the body side, it's often difficult to do because the payers are over in the specialty mental health services side. Each of these bubbles represents a point of contact that we use to try to help Sarah, excuse me, deal with her mental health diagnoses. It's also, right, a challenge for us too, because some of her neurodivergencies really impact how she perceives the world. So it's particularly challenging to have neurodevelopmental on one side and especially mental health on the other, because ideally they would work in synchronicity. And you can see her primary care providers in the middle because she really serves as the Rosetta Stone between the two systems, if you will. I apologize for being so froggy. So what I want to say is that the system has really been incredibly challenging. We've hit a lot of closed doors. We're still hitting closed doors. I know the policies. I know the resources. I'll say things like, she's a 1915B waiver kid. She's eligible for whatever. And they're like, what does that even mean? I ask for CAPS referrals. And you'll hear later about CAP. It's an amazing program. And I know how to file SARS and TAR service. Excuse me, you guys, I'm going to hop off of this. Anyway, I know how to file appeals. I know how to use all the different types of recourse that we have, and it's still super, super challenging. I'll give you an example. We've waited over 1.5 years to get neurodevelopmental testing done. She's had occupational therapy assigned to her. We put on the list in October. We were told in January to call back in July to see if we could get moved off the list. FERS, which is supposed to be an urgent response system, has us on a waiting list to see if she can get specialty behavioral health services and a RAP team. The personal, we were on a 5-year waiting list for a community organization. I'm going to wrap it up, but some of the personal pain points it's exhausting. It's traumatic for her. It's developmentally contraindicated to take her to so many different meetings. And then I have real fear of mobile crisis involvement that still has some law enforcement presence, especially as a young Black woman. So I'm always trying to stay ahead to keep her from needing that. But it's been really difficult to avert crisis with the lack of resources. Now, what we've done, individually, like without support through her benefits, is hired private therapists, family therapists, dyadic therapists, DBT providers, and a whole bunch of things out of pocket, but that's not really always sustainable. I apologize for this cough. I do want to go to the next slide, sorry. So I do have hope, and I'm going to wrap it up. I do have hope that we'll start looking at our kids as with the new policies. So presumptive eligibility, the 1915B waiver, enhanced care management, the dyadic benefit. I'm hoping, my personal dream is an expansion of CAP consults in primary care, where psychiatrists push in resources in the primary care setting, and the expanded workforce, and especially what's happening in schools gives me incredible hope. And that we start looking at mind and body together, and we in the pursuit of chronic wellness. And then instead of having a system that's divided, we really create a vessel that holds our kids and recognizes them as individuals and single people whose minds and bodies are not actually divided, but need to be treated as one. And that we don't let the issues with our payers and our funding sources be the determinant of how kids get care, that we put kids and family needs at the center, and that we really embrace, and we also work on perfecting these policies so that they're really implemented in a way that can and will save lives. And what I hope is, I hope that the little drop of that I put in the bucket or in the ocean, what I hope is that that drop means that next time, in 5 years, in 3 years, in 10 years, when there's a mama who brings a baby home or has a child and knows that they're at risk for many reasons, for behavioral health issues, that they don't have to wait till that child has a diagnosis and ends up needing specialty mental health care, because we've done such a great job with all these new policies creating a container that we're preventing that slide into that more specialized health need. So thank you, and thanks for bearing with me. I'm sorry, you guys, I really am down with a gnarly cold. And thanks to everyone for doing this panel.
Thank you, Nancy. In the interest of time, I'm going to move really quickly to Ann. Ann Kuhns is the director of the Children's Hospital Association. And Ann, I know you've been in this battle for a long time, both at the state level, but also with all the hospitals. So I'll invite you to feedback, and I think we're a couple minutes behind, but go for it.
All right. Thank you, Alex. I am going to, this is the moment where you have this panic attack because you're like, do I know how to share my slides? So here I go. I'm going to try to share my slides. Welcome everybody. I mean, thanks for being here. I hope not to take up all of my time because I know we're running a little behind, but I'm going to be echoing some of the things that both Alex and Nancy have been referring to. We put out a paper, the California Children's Hospital Association put out a paper in 2019 regarding the behavioral health delivery system. It was just a white paper based on our own experiences and kind of our observations about what was going on. And while I was interviewing people as we drafted this paper, I was talking actually to Petra, so I hope she doesn't mind me acknowledging how I got this reference from her. We were talking about, how do people enter the system and what is the pediatric behavioral health system like? And, we were sort of talking about it being a bit of a maze, and she used the analogy of saying it's a little bit like the Winchester Mystery House, if anybody knows what that is. And I've included a floor map that a schematic that I grabbed off the internet, in the sense that it sort of seems like it was constructed asynchronously and illogically, with haphazardly added rooms and doors that lead nowhere. And I want to be hopeful about where we're going to, but I think currently that's the experience that I think many people have. When you're trying to access services, it's just very hard to figure out how all the pieces fit together. And even, Alex and I have worked in this area for a while. I'm by no means an expert. I'm a sort of a policy generalist, but I came to this issue because it's becoming a very important issue to our hospitals. And even as I listened to Alex talking about the various opportunities, which I've also been very closely involved with, it can seem overwhelming. There's a lot of stuff going on, a lot of little pieces being added, and you kind of want the house to be built in a way that makes sense and that it would be logical when as you enter and you know which way to go as you're walking around. So I think about this analogy a lot just because even in my own life, I have family members who have tried to access mental health services, and it's been very challenging even for somebody like me who's very knowledgeable about the system in general. So, we think about the analogy to the house, sort of where are the doors, where do people enter, right? So mostly, if you're going to enter behavioral health services or try to access behavioral health services for your child, it's going to come via probably your pediatrician's office. But the programs, that we have in the state of California really are, intimately sort of determine how you get to access services and what services you can access. And those sort of doors for the system at large are basically through the California Children's Services Program, the regional center, your Medi-Cal managed care plan, your county behavioral health plan, or your school. I'm not going to talk about all of these because I'm not by any means an expert in all of them. But for I'm just going to briefly touch on the California Children's Services and the regional center benefits because they're not, generally speaking, they're not where you're going to get the bulk of your behavioral health services. Those systems aren't really set up for behavioral health services. The California Children's Services Program has a very limited mental health benefit. It's really only for mental health conditions that result directly from a child's CCS eligible medical condition. It has to be a very direct relationship. I had a situation where a surgeon contacted me a couple of years ago about a child with a craniofacial abnormality. And the surgeon was contacting me saying, I think this child should be eligible for a mental health benefit related to this condition. And, but, was unable to access services. And part of it was really that, again, as frequently, there's no providers out there, but also because the mental health benefit for CCS is interpreted extremely narrowly. So, and it only covers certain services. So regional centers also provide certain benefits, but mostly I'm sort of thinking about a neurodiverse child who may have a need for ABA therapy or something like that. It's really not meant to be a broad behavioral health benefit. So mostly if a child is eligible for Medi-Cal, the child's behavioral health services are going to be determined by either the Medi-Cal managed care plan or the county's behavioral health plan. I know that Nancy had made reference in her description about the mild to moderate, moderate to severe distinction. And that's like a big point of confusion because I think it meant in Nancy's case, as she was describing it, the services that her daughter needed, sounds like they really needed to be provided by the county behavioral health or the county mental health plan. But in general, there's been a lot of confusion because for adults, it's long been the case that mild to moderate conditions are covered by the Medi-Cal managed care plan and moderate to severe conditions are covered by the county behavioral health plan. That's not really supposed to be the case for kids. Under the federal, what's called the EPSDT mandate, meaning that a child who has a need for services needs to be provided those services. They don't need it. They're not supposed to need a diagnosis. So there isn't supposed to be this like division. You're supposed to be able to come through any door. And so the department recently, as part of CalAIM, really tried to sort of clarify that stance and say there really has to be no wrong door. Like regardless of whether or not a child comes to a pediatrician's office, whether or not that child has a diagnosis yet for whatever their condition is, or where they present to seek care, whether it's their primary care doctor's office or a county behavioral health clinic, those services, if the child is presenting with something that needs, that appears to need further support services like therapy or what have you, that's supposed to be provided regardless of whether it happens at the county or at the Medi-Cal managed care plan. I think what Alex was referring to earlier about how the state is kind of focusing in on Medi-Cal managed care, I think that's because they're able to hold Medi-Cal managed care plans contractually to doing more things. And so I think they're trying to push more of it that way in order to address what's been a long-standing shortfall in access to care. So I think we'll see more of that going on with, sort of an emphasis on Medi-Cal managed care. But if you need specialty services like intensive outpatient or partial hospitalization services for a child, you're going to need to go over into the county system in order to get those services. So the system today is pretty fragmented, as Alex and Nancy both pointed out. Maybe it's going to get better. I mean, I want to be optimistic about this. As Alex mentioned, there's over $4 billion set aside as part of the budget agreement a couple of years ago to create this very large children and youth behavioral health initiative. It's going to support things like new buildings, new infrastructure, and more community health type workers to help support families, funding for schooling services, training for providers, and a virtual behavioral health platform. I am a little worried about this in the sense that, and I'm sure Dr. Riley is going to touch on some of this, that some of these new things are kind of like, I don't want them to just be seen as bright, shiny objects that then are just like adding more rooms with no doors or, doors to no rooms or whatever. Because I think fundamentally, the problem that we have right now is that we don't have enough providers. We don't have enough therapists. We don't have enough psychiatrists. We don't have enough child psychologists. And while we can create more of these, so like frontline workers, maybe people who don't have as much educational credentials, but who can still be out there in the community, it's easier to train them and faster. Those people still need to be supervised by somebody who is more of a clinical or a clinician. I mean, because empathy is not the same as a therapy, right? I mean, like you want somebody who can be supportive, but at the end of the day, a lot of times the bottleneck is that we don't have enough people who are really clinically trained to support whoever it is that's out there in the community doing these frontline services. So I have a little bit of a concern about that, but I want to be optimistic that all these things are going to head in the right direction. And some of that's going to depend on all of us continuing to keep an eye on it, right? The other thing is that Medi-Cal is going to be launching a new benefit called Enhanced Care Management for certain populations, and that will include children enrolled in the CCS program, as long as they have some other risk factors like homelessness, or if they've been in the emergency department more than 3 times in the past 12 months. So ECM will provide additional care coordination, but again, it's like care coordination to where? Because they've got to get to someplace in order to actually get services. So I think that's the big question, is whether or not all of this can be built on a foundation where we still have such a shortage of pediatric clinicians to provide services. I wanted to wrap up by just pointing, I don't have a cold, but I clearly I have something going on. We did a survey a couple of years ago to just ask our hospitals what kinds of services, behavioral health services they provide. And this is the outcome of that survey. It's a couple of years old now, but it gives you a sense. We are just one of a myriad of providers that are out there in the community. And we are trying very hard, and I know Petra is going to talk about this in a minute, to sort of provide more support out in the community, particularly to primary care physicians. I mean, we also partner with schools. We provide, many of our hospitals provide inpatient psych beds, but obviously we're just one piece of the overall puzzle. And we want to be here to support our communities and to also support training, which we can do, and support, the educational resources for those people who are in the community to help get these services out further. So I'm just going to stop there, and I know we'll take questions at the end, and thank everybody for giving me the time.
Thank you, Anne. Petra, it'd be great to hear an update on CAP and everything you guys are up to.
Great. Thank you, Alex. And thank you, Anne and Nancy, for your exceptional overviews. And I'm going to try and keep things as brief as possible, but let's see, just having that same screen sharing panic. Can folks see that okay? So it's really nice to be with all of you. I'm a child and adolescent psychiatrist, and I have practiced for many, many years through Children's Oakland. I actually started off in pediatrics and then decided to pivot and do child psychiatry. And there's just so much kind of vulnerability in this group that I've really appreciated today, and feel like I just want to share that personally, I had my parents both got cancer when I was about 10 and had multiple kind of medical challenges after that. And then also the first person in my family to go to college. And so it feels, just very resonant with the senator's vulnerabilities and sharing, and with everyone here. And so that's a little bit of background, but wanted to just land with this place that you all may be familiar with, that in 2021, the AP, the American Academy of Child and Adolescent Psychiatry, and the National Children's Hospital Association declared a state of emergency in child and adolescent mental health. And then at the end of that year, the U.S. Surgeon General created a Protecting Youth Mental Health Advisory. And specifically in page 36 of that document, he called out expanding pediatric mental health access programs, which is what our program is, which I'll share a little bit more about. So the idea of the medical home is not a new idea. This is something that's been around since 2002. And the idea is that it's accessible, continuous, comprehensive, family-centered, coordinated, compassionate, culturally effective, and without barriers to access, either geographically or because of insurance limitations. And so embracing that idea, there's also this concept of what's called stepped care, meaning that not everything needs to be addressed by a specialist. Not everything is some kind of significant or severe mental illness in this case. So primary care providers are on the front lines and seeing, most kids. And so they're seeing these folks in tier 1 here. And then specialists, including mental health specialists, see this number 5 kind of aspect of the population where really reserving those specialty mental health spots for the more severe, complex, and acute presentations that really need it. And then the idea of step care is that these places in between 2, 3, and 4 can be managed within primary care with some type of support that may include consultation and or co-location with other mental health providers. Our program is what's called a Child Psychiatry Access Program or Pediatric Mental Health Access Program. And this is a map that is created by the National Network of Child Psychiatry Access Programs. This was just revised a couple of weeks ago, and it's been interesting to see kind of the evolution of this because before this is what it looked like just last year. And basically, this is not a new concept. The first statewide program came to fruition in Massachusetts in 2004, 2005, and then Washington State followed suit in 2007. And HRSA has really gotten behind this idea and has funded several iterations of startup funding for getting a program like this started and keeping it going for about 5 years. And there are 3 legs to these programs as part of the 3-legged stool. That includes real-time consultation in the moment. A pediatric primary care provider can call and speak with a child psychiatrist and be able to get some in-the-moment consultation. And sometimes this happens, during the appointment. Sometimes it happens later on in the day or another day. The second part of this is education. And this is as much about kind of delivering new information on latest treatments as it is about developing relationship and also establishing credibility so that when a primary care provider calls, they can say, oh, right, I just heard that person speak on, what to do with depression related to trauma just last month. And so it is kind of an iterative process because this is really about training the workforce as much as it is, or even more so than actually providing consultation for that particular child in that moment. And so the idea that you have, these consultation calls, and sometimes when a provider is new to it, they'll say, I feel like an intern again. I feel like I don't know anything. And they really appreciate having that person on the phone that they can talk with who's saying, yes, you did this well, and that is a great idea. And you can, move forward with your treatment plan. And then they call the next time and their questions become increasingly sophisticated. And generally a lot of PCPs, and this is borne out by research in other states, that PCPs usually participate more heavily in a program like this for about 1 to 3 years. And through that time and process, they develop certain skills and they know what they're comfortable with and then what they feel like they need to refer out to specialty care. The the third component of this three-legged stool is also help with resources and care coordination. And we do have a couple of levels of care coordination, and we're hoping to add in a third. Basically, that we do have a lot of resources on our website, and then we offer specific resources within that specific consultation. And then we have a tier 2 resource for families where, because of motivation or language barriers or other challenges, are not able to link with the places that they've been referred to. And so our care coordinator helps with that warm handoff, knowing that that really increases the linkage from maybe 20% if you just get handed a list of numbers to call up to upwards of 50% and being able to actually link up. And what we're proposing moving forward is being able to ask for resources through an electronic online request form. So this is really a snapshot of our program. And we have grown over the past 3 years from the Greater Bay Area to have sites enrolled in 33 counties. We have 1,400 primary care providers, largely pediatricians, but a growing number of family practice folks, and also nurse practitioners are about 25% of that, and then some number of PAs. And I wanted to include this because I think it's just really important to name that, we are looking at the whole child, the whole family, the whole community. And maybe people don't necessarily think about that automatically when you think about consulting with a child psychiatrist, but we really do hold these principles firmly in mind. We regularly do peer reviews and address trauma-informed care in places where that may be lacking, and use every consultation as a moment to help with language pearls and with thinking about, how to speak with cultural humility and to respond appropriately whenever possible. This is our video, which I'm not going to share in the interest of time, but I'll put the link in the chat. It's on the front page of our website, and I think gives a sense for kind of the feel of what we do. These are our current stakeholders, and they are represented by folks from really throughout California. This is a snapshot of our advisory council that's helped to advise us. And then we are looking to partner more with county mental health systems and also distinct insurers and healthcare system leaders and policy advocates, and also welcome suggestions for others to partner with. Briefly, we've been tracking who is estimated to be able to remain within primary care and may not need that referral to specialty mental health. And it's looking like about 50% or so of the consults that we're getting can likely stay within primary care rather than needing to be referred out. These are some brief quotes. And I just one that was really colorful was that one person in northern rural California said, "You guys are just incredible. I've been out here practicing podunk for 35 years, and you've helped me so much with outcomes that I would have expected." And then here, patients are appreciative that I have this access and feel more confidence moving forward with my treatment plan, knowing a specialist has advised me. Another about the timeliness of treatment, because then people don't need to wait for 6 months. And then another on reducing provider burnout, because they often feel just so overwhelmed and would rather send someone to the emergency room than try to schedule that follow-up and to sort things through. And then last, I will pause here. This is our tagline is connecting for care. And so sunflowers and some other plants communicate with one another underground through their root system to know where the sun shines more brightly and where the water pools more frequently. And similarly, we want to make sure that we're connecting for care with all of you in order to ensure optimal care for California's children. Thanks.
Thank you, Petra. We're running about 6 or 7 minutes behind, but we have a little bit of time and wrap up and Q&A to eat up. So we're not going to shorten anybody up, but I will be dropping the hammer to you in the chat as we get closer to the end of the 7 or 8 minutes. Next, we're going to hear from Dr. Kann Poulsen. She's a professor of clinical pediatrics at the Keck School of Medicine. Dr. Poulsen. Dr. Poulsen, we can't hear you yet. Oh, there we go.
I'm getting some technical assistance, but I'm having difficulty.
I think you got it. We heard you. Go for it.
Was that that's enough there? Okay.
You're doing it.
Okay.
You're on. Go for it.
Well, good morning. I'll be highlighting the partnerships that are needed to provide the foundations for social and emotional well-being in children with promise. And I represent the families that I serve through our County Department of Mental Health, as well as being a member of the ICC, the Interagency Coordinating Council on Early Intervention, for anyone who doesn't know that serves infants, toddlers, and their families. And I want to share some information I learned from families that's not in the books. From a focus group of mother and the other mothers agreed that we spend too much time and need to change our vernacular in calling our children at risk and see that our children are with promise. And they pointed out an old adage that children grow up to be that which we expect them to be. And we all tend to invest more when we see promise. So that's one of the messages I got from the families. Oops. I'm changing that. There we go. The foundations of social emotional well-being are established, as we all know, through the love and limits of early relationships as the young child learns to turn to the caregivers for tender loving care, solace, attention, and guidance, to match emotions and behaviors to developmentally appropriate expectations, and to learn to have the initiative to explore, discover, learn, problem solve, and make friends. And when you think about it, these are the elements of good mental health for all of us. And for our children, the journey may be different for different children, but the pathway is the same. And after working with children for 50 years, I have never worked with a child that hasn't changed over time when we invest. I think I need. All right. And looking at the protective factors, we know that every parent needs support. And partnerships for parenting start right at the beginning, especially if there is another partner in the house, or there's extended family, or their neighbors. However, in California, we have thousands of mothers without a partner, isolated from families of origin, and without social supports. All these mothers need a community of moms. And we know that there are thousands of families needing to partner with special healthcare, special mental health care, and special developmental providers in order to address the vulnerabilities in their children who have promise. And then we know that it's self-evident that we need partnerships looking at health, nutrition, and sensitive temperaments. And I think Kaiser really pointed this out several years ago, that we know that if one has a large enough family, you may very well have a child that has a sensitive temperament that tends to experience the world and respond to the world in a much more robust way, and need hothouse parenting. And the families may need, the inexperienced families may need added supports. All right, another protective factor we all know about is psychosocial family functioning. And we all know that all families have disruptions, and probably the bigger the family, the more disruptions. However, disruptions are fine as long as they're repair. It's disruptions without repair that are harmful. And then, of course, we know that a child feels more secure when their routines and their rituals are predictable to them. And finally, a very important predictive factor are what are the environmental family circumstances. And we need to assure that families have food, shelter, safe neighborhoods, opportunity, and freedom from the overwhelming stresses that we have in our society due to discrimination and racism. Now that I've addressed some of the protective factors, some partnership needs, let's look at some well-known challenges. Now, we know that our shared culture diversity enriches our lives, indeed is our country's strength. However, the divided language, culture, belief, and knowledge contributes to the disparities in the United States. And from my experience of working with Part C families and families served through our county Department of Mental Health, I see that access to services is the disparity in it abounds, especially for our non-English speaking mothers, particularly those that are new to the United States and come alone. It also, there's disparities for minority, racial, and ethnic heritage families who have a history of not being helped by the helpful professions and tend to stay away. For homeless or high mobility families, there may be a lack of that stability in where they're staying, so they get lost and a loss to contact to the provider. And finally, there's a fear of deportation I see in many of our mothers, particularly a couple of years ago, that were worried about coming because they would be picked up and provided and be deported. And then besides that, the disparities come from socially isolated families, our tribal families, and our families that have limited socioeconomic resources. Now we know that adverse childhood experiences presents a major challenge, but the good news is that the ACEs can now be screened through the PEARLs. The tool that stands for Pediatric ACEs and related life events. And now with 2-hour training under Medi-Cal managed care, health providers will be funded $29 for each screen. And related life events is added to this, looking at food security and housing. Of course, the questions are as how frequently will the screening tool be used? And even more importantly, what is the quality of the needed follow-up? When it comes to our children, the notion of cumulative adversity asserts that the greater a number of negative circumstances, the greater will be the call on the child stress system. And if they don't have the resources to deal with the stress, we know there's negative developmental outcomes. And we know that cumulative adversity dysregulates the nervous system, and chronic stress becomes toxic and can affect the architecture of the brain. So with toxic stress, we have increased levels of cortisol. It destroys the brain cells and connections between the brain cells. And it also changes how the child experiences the world and reacts to the world in terms of impulsivity, emotional reaction, and their behavioral responses. And then we also have some root challenges to our system. One is the lack of the professional skills for the provision of trauma-informed services that Petra spoke about, related to adverse experiential repercussions. And with that, a lack of coordinated services and community supports that address family and adverse circumstances. So I think it's really fascinating from the 2021 National Survey of Children's Health that noted that many Black children live in neighborhoods that lack amenities, But the data also show that those neighborhoods that had sidewalks, recreational centers, parks, and libraries had children that had a higher level of social, emotional, and physical health and higher academic achievement that they saw in the adolescents. So in conclusion, we need to look at a public health model that vulnerability is not destiny, but we need to focus on positive mental health, both prevention and preventive intervention before treatment is required, to address problems with trauma-informed care, to address vulnerability and protective factors that influence family well-being, and to engage community partners in a comprehensive and coordinated way. And I just want to comment that Pasadena has an early childhood policy that just has come out on partnerships that their mantra is united in vision, but also linked in action. That it's not just collaboration that could be sweet talk, but there's no wrong door in coordination that you follow through. And of course, always to implement family engagement in culturally driven and family driven way. So in conclusion, putting the partnerships together to support children with promise will lead to meaningful and successful inclusion and belonging. And of course, that is the start of all mental health.
Thank you, Dr. Poulsen. Delightfully, I get to now invite Dr. Pam Riley, who is literally our captain at the Department of Healthcare Services, and sort of just an extraordinary leader that is, we're grateful to have you here, Pam. Please take it away.
Hi, good morning. Thank you, Alex, and thank you, everyone. It really is a pleasure to be here with all of you, the panelists. I've learned so much from you already in terms of just listening today. So it's been very informative to me, as well as in terms of what works and what doesn't, and what we can do to make it better. So I am at DHCS. I joined last year as Chief Health Equity Officer and Assistant Deputy Director for Quality and Population Health Management. I am a pediatrician by training, and I also serve as the DHCS Child Health Champion, which really means I get to work with all of you in terms of how do we better understand, coordinate, provide what is needed to make things better for kids and families. So my interest in really doing this work stems from my time as a general pediatrician practicing in a community health center, really seeing how when Medi-Cal works or when it doesn't work as well as it could, what that impact is, and how do we use Medi-Cal to really design care and systems that meet the needs of children and families in a comprehensive and coordinated way. And as you've heard from all of the speakers this morning, California and DHCS Medi-Cal in particular are taking lots of steps to try to sort of set the floor for how do we do that. But it will require a lot of partnership from all of you in terms of identifying where do we need to work effectively, more effectively together to fill in some of those gaps and really create a more coordinated system that hopefully does not remain looking like the Winchester Mystery House. But anyway, so I wanted to run through just a few of the what we have in place already, and you've heard already about some of the newer benefits that Medi-Cal is implementing. Let me just switch my view here. Excellent. We've heard quite a bit from all of you, and Alex, I wish I'd had your Medi-Cal 101 when I first started. That was excellent. But wanted to just sort of highlight that DHCS, largely through CalAIM, is really focused on improving care and creating a more comprehensive system of care for children and families to make sure that kids get the care that they need when they need, in a way that meets their needs. And the Medi-Cal strategy to support health and opportunity for children and families was released last year under this umbrella to really sort of strengthen the foundation of children's care and identify areas where more attention is needed. So under this umbrella, there are several existing benefits as well as new benefits that you've already heard about that I feel like are worth mentioning in this forum. And these things are not specific to behavioral health or to necessarily to children with special and youth with special healthcare needs, but certainly stands to benefit all of those.
Pamela, I didn't
Yes.
mean to interrupt, but we can only see the presenter slides, so the folks aren't getting to see the full slides.
Okay, so how do I change that? Let me try it one more time. Thank you for letting me know. Did that work or not?
How about slideshow?
Yeah, just click on slideshow and then you should,
Yeah,
the top next to animations, click on the
on
link
mute,
that says
Pam.
slideshow. Next to animations on the top of the screen. You see file, home, insert, draw, design, transitions, animation, slideshow. Yeah, click right there.
thank you.
Mhm. Yeah.
Pam, just a heads
I'm not
up.
sure what's happening. Yeah, so why don't we just move on? Because I'm not, something is wrong with my platform today. So I apologize for that. Are you able to at least see the screen with these slides on it? Okay, so we'll just do it like that. My apologies, not sure what's happening. But part of what we wanted to do is really just sort of say, like, we've talked a lot, we've heard a lot about what some of the newer benefits are that are coming, the wonderful dyadic. Alex could tell you way more about that than I have, and some of the newer behavioral health no wrong door benefits. But one of the things we realized that we do need to do is educate and inform members, providers, plans about the benefits that already exist and that all kids should have access to through Medi-Cal. So we just launched last month our Medi-Cal for Kids and Teens Outreach and Education Toolkit to really answer the question, what is EPSDT? Early Periodic Screening, Diagnostic, and Treatment Benefit is really the floor that sets the expectation for all of the comprehensive screening, prevention, treatment services that all Medi-Cal children and youth have access to, anyone under age 21. And the challenge with this is that we've seen historically a lot of challenges with kids who are not getting the care that they need, not just the primary and preventive care services, but also the treatment services, particularly behavioral health. So really, EPSDT is the comprehensive benefit, more comprehensive than it is for adult, to really ensure that kids and youth get the right care, the right place at the right time. And in that interest, we have launched a toolkit that includes member-facing materials geared towards teens, kids, about knowing what these benefits are, knowing what your rights are under the EPSDT law in case you are not getting the benefits that you need. And we're also educating healthcare providers about what these benefits are. And again, while these are not specific to behavioral health, it includes comprehensive behavioral health services. And we actually will be, in terms of, we're working very proactively to disseminate these materials, not just through the health plans, but also with partners, including many of you on this call. But one thing that we've heard consistently is we need to kind of call out that behavioral health component so that kids, families understand what it is that they have access to and what it is that they can advocate for. We also want providers and plans to know that information as well. In terms of the new benefits, I won't spend much time, but you've heard about the dyadic benefit, which is really a remarkable story that Alex and colleagues sort of started with, that sort of member facing on the ground, care provider ground up. What are the needs? What is the model to meet those needs? And then how do we design the Medi-Cal benefit to really support that care delivery, which I think is a remarkable story, and really the dyadic benefit, sort of thinking through the prevention treatment. How do we really start sort of on the early side of early identification and intervening to provide that behavioral health support to the entire family. And this benefit went live in Medi-Cal just in January. In terms of, there are several behavioral health specific benefits that we have alluded to throughout this, but I think the most important thing is this. Children do not need a diagnosis to access behavioral health services in both the managed care system and the mental health system. And we are making attempts to streamline those criteria, the medical necessity criteria, to match the benefit of EPSDT, improving access to enabling no wrong door, improving screening and streamlining of coordinating that care. So there are a lot of changes underfoot that we hope will support that more comprehensive coordinated system. I did want to touch on the enhanced care management benefit that has been mentioned before. It really is, there is a continuum of care, of care management that all managed care members have access to. Enhanced care management, or ECM, is really intended to be the coordinator of all of the care management and services, and really incorporates social risk for the first time, in addition to high needs medical conditions, in terms of being eligible for a more intensive community-based, family-focused care coordination approach. And just to share with you, this is just the continuum of care. ECM is really for the highest need members, which includes health and behavioral health and social needs. And starting in July of this year, these are the populations of focus that will be specifically eligible for enhanced care management, which includes children with serious mental health and substance use disorder needs, children with complex medical conditions, including those enrolled in CCS or whole child model, with additional needs beyond their CCS condition. I won't run through the whole list, but really the intent is to serve as a resource focus, really more intense care coordination for the kids who are really at highest risk, including those with behavioral health needs. I will also just touch on the Children and Youth Behavioral Health Initiative, which you also heard about, which is really re-envisioning the systems of care that support behavioral health for California's children, youth, and families. It is run through California HHS, and DHCS is responsible for supporting some specific aspects of this, scaling evidence-based practices and community-defined practices. Will hopefully help us get to a place where we are able to pilot, spread, and scale interventions that work to better support the behavioral health needs of children and families, and also to support that infrastructure to really build out not just the behavioral health and healthcare systems, but also schools and other systems to really provide more comprehensive levels of support to children and families. So lots of stuff. This is a great discussion. I will stop there and look forward to the Q&A. Thank you very much.
Thank you, Pam. All right, let's close with Cheryl from DREDF. Cheryl, I don't think you need an introduction, but for those who don't know her, Cheryl is one of the leading lights in the state in making promises practices. Cheryl, please.
So just give me a minute to share my screen. 1 second.
And for the timekeepers among us, I think we're going to be really close to still having about 10 minutes left for Q&A, so we should have enough time. Thanks.
Thanks. Can you see this okay, Alex? Okay.
Yes.
Good morning, everyone. I'm really honored to be here, and I'm honored to be part of this panel. I want to bring us down to the place where a lot of this actually plays out. And that is at school. And the parent training and information centers, and we here at DREDF have one, it's where I work, are available all over the country to help parents and families and youth engage meaningfully in education and make sure that people know how to use their rights. But as we know, and as we've heard this morning, that's easier said than done, and it can be an exhausting process. I want to start with something around behavior that Judith Heumann, who just passed away this past weekend and who we consider the mother of the disability rights movement, said about safety, because I think it applies to behavior very often. This is the language that we hear. She says, but I was beginning to learn something very important. When institutions don't want to do something, to claim that something is a safety issue is an easy argument to fall back on. It sounds so benign and protective. How could caring about safety possibly be wrong or discriminatory? So I just wanted to use that to frame some of the points I want to make here. And I'm going to go fairly quickly because I think the Q&A is really important. First of all, children's mental health and behavioral needs at school are more than just a parenting issue or a compliance issue. It's a community problem for us. You know, some of my fellow panelists have already talked about the number of children who need support around all of this. There's been a huge increase. And I just would point you to the picture at the bottom of my screen. This is how I think many families feel. Go this way, go that way. No, wait, back up, go the other way. Oh, wait, no, I don't do that. This other organization does that. And it's extremely challenging and it's exhausting for families. And families who are dealing with behavior and mental health needs of their kids are stressed. And so then we're asking them to become the navigators and the case managers as well. We also don't listen enough to what families and youth themselves are saying about what it is that's going wrong for them, what they need, even though we know, and a lot of the federal protections are based on the fact that families are the most important source of information about their kids. And then I also just can't represent DREDF without talking about disability discrimination and ableism. And ableism, like racism or other forms of discrimination, is this set of assumptions that people with disabilities need to get fixed, and that it's not a disconnect between a child, for example, at school and their environment who needs a ramp for a wheelchair. It's a problem of the child internally. And when it comes to behavior and mental health, I see this, we see this, the parent centers across the state see this. We fail sometimes to ask the right questions. We work on behavior plans and behavior approaches that focus on getting us the outcomes that will make the child easiest to deal with, rather than addressing where's the disconnect between what the child needs, the environment they need to operate in, and the environment that they're in. What can we do? I certainly think that another major issue right now, and I think COVID has made this, I don't want to say post-COVID world because there's nothing post about it, but at any rate, we're still reeling from the consequences of a lot of the COVID experiences at school, is that there were already trust issues, especially among certain communities. For example, DREDF does a lot of work on the North Coast with some of our Native American tribal members, and they couldn't get equipment, they couldn't get access, they didn't get services, and there's already a long history of intergenerational trauma and education being seen as not necessarily an institution to be trusted. So when we talk about behavior, we have to start by talking about relationships and trust. Some of the key problems we're struggling with as a state right now, first of all, this thing called child find. So there's a federal obligation under the two education laws. Actually, 504 is a disability discrimination law, but there's a requirement that whether it's under Section 504 or whether it's under the Individuals with Disabilities Education Act, and just so I'm not throwing around too many acronyms, IDEA is the law that establishes special education and an IEP. There's a requirement that schools, juvenile schools, court schools, county schools, charter schools are public schools subject to all the same laws, that the obligation is to go out and find kids who may need to be evaluated to see if they need help. And instead, I think the experiences of so many of our families, and I think our community providers see this too, we get many calls here at DREDF from community providers asking us to help families, is that instead there's often barriers. So for example, We see barriers in terms of family blaming. You know, have you tried a behavior plan at home? Do you put the daily schedule on the refrigerator? You know, what is it you could do? Like, this must just be an indication that you're not a good disciplinarian or something like that. Certainly, we see disparities between who has resources and who doesn't. When you can go out and buy a private assessment and then show it to the school by a highly trained specialist, you're in a really different position than when you're a homeless family whose van is parked, as I had a family recently, in front of the school so that your children can go into the school and brush their teeth before they go to school in the morning. We're dealing with some major systemic issues right now around resource shortages. So, you know, we can talk about children needing mental health support and counseling and other kinds of services at school. But when your teacher is a sub who changes every month and who isn't adequately trained, we're really not we're focusing on compliance. We can check the box that the child's getting teaching, but we can't really say that we're providing effective interventions. We're also seeing huge problems around attendance for children. And, you know, kids who don't go to school are often denied an eligibility evaluation because the assumption is that they must just be avoiding school, and that's a family problem. It's family's law. The law requires the family to make the child go to school. In fact, it's a big red flag, and we know that. We know it's a big red flag. When a child is not going to school, it's not so much about refusal, it's about inability. And I have parents calling us who have kids having panic attacks and can't get out of the car in the morning and are stressing. And finally, we have this whole wait and see attitude about, you know, don't worry, give kids time. Let's not, you know, jump too quickly to interventions and assumptions. But the problem is that in our experience, once that first domino falls where a child starts to go into crisis or a child feels unseen, unheard, unrecognized at school, then you're going down a path where you end up needing to provide much more significant interventions. It's costlier in every way, not just financially. So a couple of points I just want to make here. I'm going to race through this a little bit. First of all, you know, the goal of educational support in whatever form we give it, whether it's through our responses to intervention approaches, or whether it's through IEPs or 504 plans, all these acronyms, the goal is that we want to teach our kids, just like we all have had to learn, how to use our strengths to overcome our challenges, right? And so if we think about disability as what is the child not getting, that what can't they access at school that's creating these barriers? And we think about that not just in terms of a child maybe who's a wheelchair user, which is a huge issue, but also a child, for example, who has really significant problems with dysregulation or sensory overwhelm. Then we come at the problem differently. What we see are behavior plans, for example, that are based on, there always seems to be two basic reasons for the child's behavior. They are either avoiding the work or they are escaping the classroom. And that doesn't really give you any information about what you actually do to help that child access their education. We're asking the wrong questions. We're measuring a child's compliance instead of a child's learning. We also don't take nearly enough advantage of the family consultation. And I think we talked about this a little bit yesterday in the one of the panels. Family consultation can be a service. And even under Section 504, families will say, oh, well, I was told that's just for kids who don't need special education. They certainly can receive special education services if it's needed to create equal access to educational opportunity. So, you know, there's many of the issues I have here have already been discussed by my colleagues. I will say that something that the senator said at the opening of this session is really important. Students who struggle with learning and academics struggle with behavior. And let's remember that behavior is not just acting out and creating problems for the teacher. It's opting out and not going. It's giving up on yourself. It's acting in and putting your head on that desk and just not engaging. You're not a problem for the teacher, but that's a behavior too. So we need to think about how we're going to support kids, not in terms of behavioral compliance, but in terms of access. And then just two quick things around discipline. We know that there's huge disparities in discipline in terms of race and disability. We know that students with disability are twice as likely to get suspended as their non-disabled peers. But what we don't look at enough is the effect of school trauma. We're really good on our ACEs inventories and checklists at looking at trauma in other settings. But for a child who's having trouble learning, or who can't self-regulate at school, or who's being sent out of the classroom or told not to come back, those children are experiencing trauma at school that then creates mental health needs in the community. It doesn't just work the other way. And for children in foster care, I see this all the time, where their home placements blow up. They're asked to leave their group home. Their foster family asked for them to be placed elsewhere because the school is calling, the behaviors are escalating, and the help is not being provided. So as we, go through all of this, it's important to remember, and I always include my restraint and seclusion slide, because one of the big problems we see across the country is this emphasis on compliance, and even programs that will say your child can come to our non-public school or our counseling enriched classroom, and here's our behavior plan. We're going to do this, and we're going to do this, and we're going to do this. And then if they don't do all of those things, then we may need to restrain them, which creates a great deal of school trauma. So I'm just going to wrap it up there by saying that when we talk about mental health and we talk about behavior, the silos are completely artificial when it comes to schools. Kids spend hours at school every day. Kids' future educational outcomes are determined by what happens at school. Families are stressed by unmet needs in school. And so, these sort of intersections of healthcare, mental health care, educational care or needs are all completely interrelated. But right now we have a system where families are the ones who are expected to be the case managers and navigators of that. And that's something we need to work on as a state and as a country so that we can create equal access for all our kids. I'll leave it there. Thanks.
Wow. I love hearing you talk, Cheryl, and I couldn't help but reflect that if we continue to build systems for the people who work in them and not the people who need access to care in them, we get what we got, which is this impossibly difficult, challenging thing to get through. Thank you so much for your leadership and advocacy. I wanted to note that for many who posed questions in the Q&A, thank you so much, Cheryl. Panelists have been great jumping in there and answering them direct and creating links and stuff. So we are a little constrained for Q&A time, but a bunch of Q&A work has been done as we go, which is really fun to watch. So with that, I think we're going to have some help sifting through the Q&A to answer questions for the last 10 minutes. I think that's correct. If not, I will drop in, but that was my understanding of the next step. Yeah, please, if all the panelists could jump back onto video, that would be great. I'm looking at the Q&A. The only Q&A that is unanswered right now is, in California, how are schools mandated to inform parents of their child's possibility of a 504? I feel like that would be a Cheryl question. And we also
Can you throw it back at me one more time, Alex? I'm sorry.
Yeah. In California, how are schools mandated to inform parents of their child's possibility of a 504? I think that means eligibility for 504s. Like,
yeah. I think as many of those of you on the panel who work on the healthcare side of the house, it's often you guys who are telling a family that they could get these services or that they should ask for an evaluation, in part because I think there's this, well, again, it relates in part to the ableism issue, but also to the resource issue. There's this fear that we don't want to label kids, we don't want to stigmatize kids, we need to try other interventions, all of which can certainly be true. But it leaves a parent in the position of having to be the person who's knocking on the door. And that's why I included that child find slide. Schools are supposed to help. I had a school that had a child run out into traffic saying she wanted to die, but who wasn't referred for any kind of evaluation at school. And they felt that it was family problems. There's that sort of parent blaming thing, or, the family's going through divorce, it's natural. I would also say that this is a place where parent centers are very helpful because we have a million resources to help you access these kinds of services. But you're exactly right, the person who asked the question. If you don't even know what questions to ask, then you get completely mired in this sort of maze. So I think it's really contingent on all of us to create the kind of screening, to work together to make sure that the problems with behavior are always seen as a form of communication. That child is telling us that something is wrong, but something is not working for them at school. And we need to get in front of that. And then I just want to add quickly, I also think the other problem is that there's this cookie cutter approach of, if your child has autism, they get this kind of service. If your child has ADHD, they get this kind of service, instead of recognizing that every child can have mental health needs. Every child can have behaviors. Most children in our state and country who have an IEP, for example, are learning disabled. But if you don't address somebody's learning disability and you don't help create access, you're going to create a whole another set of problems. That's what we see when we think about behavior.
Mm-hmm. Cheryl. If anybody else have anything to say on 504s? I mean,
write a letter.
I can't help but comment that lawyers are the new social workers. Like, you need one to get through the thing. But second, like, schools have this obligation under the IDEA and other obligations to assist children in getting a free and accessible public education. But there's a confluence of things happening here. We're seeing schools not only become places where you go when no one else will help you. That's what you're hearing, right? And that's unfortunate. That's the place that we all kind of devolve to when there's nothing else, get an IEP. But we're also seeing the kind of emerging role of schools as points of first contact for behavioral health support. And I think they are not the same thing, though they are both happening in the same place. I did see a question from Orange County in the chat. I posted the CalAIM timelines. And then I saw a second part of that question from Steve, which was, how can new to Medi-Cal billing providers serving our underserved communities get DHCS focus and urgency? This is a really big issue, you guys, the question of how to sign up to get paid. And it's a huge, particularly for providers of color. We've been, Pam, I haven't even talked to you about this issue, but just helping folks navigate getting an NPI and getting approved by the state, but then knowing that that's just the beginning. You then got to go to the local payment system and get paneled and credentialed with the payer locally, be that the county mental health plan or the managed care plans that serve your county. So this multi-stage process of being invited into the provider network is a really, really big problem. Steve, I'll send you an email and put my email in the chat, and you're welcome to email directly. I'm very much interested in this question of how to bring new providers in, particularly providers that have cultural congruence. And it's a multi-stage process. The answer is you got to register with the Fed and the state, and then you also have to panel and credential with the local payers. Pam, anybody else want to comment there? I wish it was easier.
I will just say that I know Alex will keep me informed. But yeah, this is definitely on our radar as well. And we want to be able to support these alternative provider types and actually being able to participate in the system. So definitely a concern for us as well.
I think we've got a new question here in the Q&A. Cheryl answered the link to the free parent training. Parents are the anchor for children who fall through the CAP. The mental and emotional challenges they experience when they're, man, what a great question. Thank you so much for this question. The anonymous attendee who posted it, at what cost the caregiver? And Nancy, I know this is just something that is like, it's your life's work.
Yeah.
So I'd like to invite you into any comments here. I know there's other.
Yeah, thanks. I mean, there's so I founded Kids and Caregivers because I could not believe that there were no resources for caregivers. There's a lot of evidence showing that we are at risk for health conditions. Our own personal health is at risk. And also that our children's health is at risk. If we're not well, our children are not well. If we can't advocate successfully, our children are not going to do well. So I partnered, and there's some other good programs out there. I partnered with USCF, some physicians, and we created an evidence-based program to help caregivers deal with their stress. I think, and also some mentoring programs. I think there's a very real issue around, I saw that in the question, the issue of retaliation. It's a balancing act, right? Like, you want to be a strong advocate, but you also don't want to alienate the people who have power over what happens to your child's access. And I think that the more we talk about that, and that's why I appreciate this question, the more we can start kind of peeling back that power dynamic, because it's troubling. You know, I literally will say things to people like, I don't want to alienate anyone, but my daughter's covered by the 1915 be waiver. Like I'm apologizing. I feel almost apologetic at times as a strategy, not because I'm actually apologetic. I mean, my daughter's rights are her rights, but I really appreciate this. And so there's some groups of kids and caregivers. And I will say that there's been some promise. I'm starting to do some work with, not in California, but some other states are looking at locking in caregiver wellness resources as part of Medicaid, as part of their benefits. When a child's got special health needs, they're looking at how to make that a part of what the family gets to explicitly address caregiver wellness. And I have high hopes that we're going to get there at some point too, because I think it's a vital part of the system of care.
On the practical front, I would just quickly name, for parents involved in the child welfare system, parent partners are an really important resource, and local NAMI chapters almost always have consumer or caregiver support models as well.
Can I just add one thing, Alex? I also think it's important to remember that culturally we have so much diversity, and it's wonderful, but it also means for some groups in some communities, being in a meeting with a doctor or school or whatever is, you don't challenge, it's considered disrespectful. And so, I think that creates a lot of barriers for families.
That's right. And I mean, the other piece I want to reference to is I think that the development of the new workforce categories and the focus on peer-to-peer and the coaches, I think really has hope, because I think that by providing peer support, especially for caregivers, and the programs that I've worked in are really peer-based, that it speaks to some of the issues that Cheryl's raising, because it's not going to be a one-fit solution because of the diversity of our state and the diversity of needs for support. So I really find a lot of hope in some of the mutual aid, peer professionals, some of the health coaching programs, and look forward to seeing what develops with those as a pathway to create meaningful, culturally concordant and really impactful support for caregivers.
So with that, you guys, I'm gonna wrap us. I want to say thank you, everybody, for your contributions. To frame something that Nancy said, and in departure, there's an amazing book by a woman named Mia Birdsong called How We Show Up. And it's the story of how queer it's a story of many things, but one thing the book does is talk about how queer Black women in Oakland build community and support each other despite all of the challenges they face. And to reflect Nancy's really important feedback, the future of mental health looks a lot less like a psychotherapy session and a lot more like a support group, a lot more like people with lived experience supporting and helping each other, clinically articulated, but not necessarily clinically intermediated. And I think somehow we all have to kind of decolonize our mind and democratize mental health as something that we can offer to each other and between and among impacted people, and mine the experience of folks who struggle for the answers to all of our problems. Thank you for coming, everybody. And with that, we're done.